nice flip side of things, evidence that you've shared with us. I would just like to pose one question to you. When do you think, as from a radiosurgeon's perspective, when would you advocate or push, or say not push, advocate for gross total resection in a craniopharyngioma? We've seen spectrum of cases, but in your opinion, when do you go for gross total?
Craniopharyngiomas are not very frequent tumors. We do see it 1 in 1 million. For example, in Turkey, 85 million inhabitants, only 80 something craniopharyngiomas in Turkey every year. So all the neurosurgeons shouldn't need to operate craniopharyngioma. So the experience is very important. Experience is important with surgery, and also experience is very important with radiosurgery also. So if you get an education with an experienced surgeon, who performs craniopharyngioma surgery a lot, then you can understand when to push for gross total resection, when to try to get gross total resection, when not to have. You may discriminate between only the adherence of the tumor to the optic nerve or the infiltration of the optic nerve. So I would recommend to the young colleagues, as Dr. Ali said, that they should need some good experience from the good education from the experienced surgeons all over the world.
Understood. So thank you for that perspective. So, it's nice to hear both sides of the coin. Now, I think, we are inspired by both your talks. Our last speaker is someone who needs no further introduction. Dr. Paul Gardner is a name synonymous with skull-based surgery, and he's here to share his perspectives on, managing recurrences in the multi-modality setting. Paul, over to you.
Thank you. Thank you for the invitation, and congratulations for a great webinar. We've heard some very clear impressions that I think set this talk up very well. This is kind of a difficult talk to give. I sort of had to figure out how I'm going to try to simplify this concept that's very challenging, but recurrence is a very common thing in craniopharyngioma. There's no question that you can prevent this with gross total resection. There's also no question that gross total resection tends to have higher morbidity. So inevitably, there's going to be some adherence to optic pathways of the hypothalamus, which can lead to higher recurrence rates depending on the tumor. Some craniopharyngiomas are more resectable than others. Looking at our early series here, we're able to achieve gross total resection in only about half of patients, and most of the rest had near total or very rarely subtotal. Very rarely less than 90%. And here's a great example of a case where we used stock preservation. And I'll sort of skip through this in the interest of time. But here you can see opening, a typical suprasellar opening that we would use. Oh, sorry about that. This all right, you still able to see my screen okay? So typical suprasellar opening. And here you can see the opening right across the superior inner cavernous sinus, which we can coagulate and cut. And we can try to visualize which areas. One of the advantages of this, obviously, of an endonasal approach is there's no brain retraction, but also we can directly visualize the tumor and the surrounding vasculature. So here we're opening into the initial cyst wall. We can be very careful to preserve the normal superior hypophyseal vessels. And this is very much like, in some ways, acoustic neuroma surgery, where there are two arachnoid planes. If we respect those arachnoid planes, we can quite easily find the right plane with the tumor and the hypothalamus and often get a complete resection. And here you can see just dissecting that hypophyseal vessel off. And we've seen some great videos of this, so I won't spend too much time on it. But here's a beautiful example of this inner layer of the tumor against the hypothalamus. And one of the advantages I like about the endoscopic approach is the ability to see exactly where that plane is with the hypothalamus. It's really the only approach that visualizes the entire hypothalamus while you're resecting it. So here we can resect up to the floor of the third ventricle. And one of the things I want to show here is that, stalk preservation is possible. Here we're getting a pretty radical removal of all of the tumor on the hypothalamus. But at some point, to avoid transecting the stalk and trying to preserve function of a pretty thick stalk remnant here, we perhaps leave a small amount of tissue, which we can't tell is inflammatory or not. So here's the post-op where we're able to preserve the stalk, and in this case, the patient preserved function as well. But it's true that preserving stalk function does increase the risk of recurrence, and so it's important to understand all of these trade-offs. And I know Dr. Krish doesn't like talking about the learning curve, but I think it's very important because all of us have a learning curve, but we have to dedicate ourselves to making sure we overcome that learning curve and stick with it. That's sort of the point of talking about it. But the more resection we get, the more pituitary dysfunction we get. They are directly sort of in counter to each other. So in trying to preserve pituitary function, we can have higher risk of recurrence. But remember, recurrence leads to loss of function. So there's a constant balance here with craniopharyngioma. So tumor recurrence in our series was seen in only about a third of cases, but the only significant factor was gross total resection. As Dr. Krish said, this is really critical, and this is with a pretty reasonable follow-up. Interestingly enough, in the patients who underwent near total or subtotal resection who had adjuvant either radiosurgery or radiation, they did not have the same lack of recurrence as gross total resection, so it did not seem to have the same benefit. Only gross total resection did. So how do we manage these recurrences when we really get to them? Well, it really depends on what kind of tumor you have, what's the prior treatment of the tumor, what symptoms does the patient have, where exactly is the recurrence, is it solid or cystic, and what's the patient's function, both of their pituitary and otherwise. Histology is very, very important when we're looking at recurrence. And that's because adamantinomatous and papillary tumors are probably very different. They're very different genetically, and they have different mutations. You can see the adamantinomatous, which is the majority of craniopharyngiomas, has this CTNNB1 mutation, whereas papillary harbor BRAF mutations. Now, BRAF inhibitor treatment, remember this only applies to papillary craniopharyngiomas, which is the minority of craniopharyngiomas. And the truth is not every papillary harbors BRAF, but about 90% of them do. So here's a recent study looking at BRAF and MEK inhibitors that was published in New England Journal. This is the group with Fred Barker. And looked at 16 patients, and you can see most of them had a reasonable response, but 3 of them progressed. This is a relatively short-term study. This is a significant chemotherapy, and 3 patients had to stop due to adverse events. And the progression-free survival at 2 years is approaching 50%. So this is not a perfect treatment, but it's a great option, I think, in recurrent tumors. Similar multi-center study done in Europe with very similar responses, and you can see discontinuation in 5 patients and well tolerated in the majority, but it is not a perfect treatment, but a great option for especially recurrent papillary tumor. When you have non-papillary tumors, though, you really have to look at, again, I think the primary drivers here are where is the tumor, is it causing symptoms, and then is it solid or cystic? And here's sort of a little chart I came up with for this talk, and I'll sort of go through some cases here to show examples of how this can be used. So here's a patient who previously only had this cyst treated with P32, no prior surgery. It's a recurrence. The patient's presenting with vision loss from that optic compression on the left side. So yes, it's symptomatic. Here we can see it's a combination of cystic and solid. And it's already undergone an intracystic treatment and failed that. So this patient should have a resection. Now, what approach do you choose for resection? Well, I believe in the rule of not crossing the nerve. This is how many of these approaches were developed. And craniopharyngiomas are inherently a retrochiasmatic tumor. They originate from the stalk, they originate from the hypothalamus, and they sort of herniate forward up against the chiasm. So the most a craniotomy can be used anytime the tumor is above the optic, such as a third ventricular tumor, or when they have large cysts lateral to the nerve. But in my hands, an endoscopic approach is preferred for all, and I really believe there's some very clear advantages. So, so here we can see some of the advantages of endonasal approach. It's a very natural corridor. You can allow that early stalk identification, and I think it's the best visualization of the hypothalamic margin. Here's that inline corridor. It's the trying to line up your approach with the long axis of the tumor, and an endonasal approach really is the best option for this. This is that patient after P32. And here you can see the advantage. Our concern here is the margin with the chiasm and with the hypothalamus. And you can see how well we can visualize that margin. So there's no other approach that gives us this kind of visualization of the margin between the chiasm, the hypothalamus, and the tumor. So you can decide to be as aggressive or non-aggressive as you want, depending on your comfort. But you can really visualize that gliotic plane to be able to try to carefully preserve it and get a complete resection, which was done in this case without any hypothalamic injury. So what about this man? He's initially presented here. He's got a 78-year-old man with vision loss. And here you can see a significant recurrence. So again, he's someone who has symptomatic, so he's not really recurrent initially, so he should have a resection. But after resection, he eventually had a small recurrence here. You can see it impacting that right optic nerve. So this recurrence, though, was asymptomatic. So because it was asymptomatic, he was actually treated with radiosurgery to this area. Another year later, though, unfortunately, this developed vision loss due to a cyst formation within it. So as a result of symptomatic recurrence, now he underwent a repeat endonasal resection. So you can see this trade-off between the two techniques. And then now, again, 2 years again later after that, he has an asymptomatic recurrence on the opposite side. So not where he had the prior resection, not where he had prior radiation. So asymptomatic recurrence, it's safe to do radiation in this location. So he underwent radiosurgery, and it was sure enough decreased 1 year later. What about these extensive cysts? I agree completely. These are really a different beast that we need to look at. So here you can see a pre-op and a post-op of a patient with a multicystic tumor. And here you can see nice pre-op and post-op, but these are very commonly recur. So here's a delayed recurrence of a cystic tumor. So again, it's cystic, it's not symptomatic. So we start looking at the radiation arm of things. And the real question here, as you saw in that prior case, is radiation or stereotactic radiosurgery safe? And what I mean by that is, what is the prior optic nerve dose? How can it be given safely based on size, given the optic nerve and optic radiation dosage? So in a case like this, it's really quite far away from the optic itself or any critical structures. It's just by the cerebellum and the CP angle. It's not even close to the cochlear nerve. And it's around the 2.5 centimeter mark. So this patient was given radiosurgery. And sure enough, you can see that patient actually managed quite well. It looks like I don't have the follow-up, but this actually decreased with time and the patient needed no other treatment. Here's another very large frontal cyst, underwent resection of the solid component, drainage of the cyst, but the cyst recurred. So how can I manage the cyst? Well, we know it's cystic. It is somewhat symptomatic, but this patient was just treated with an intracystic treatment, in this case P32, which is not really available anymore, but bleomycin can be used as well, and a very nice result for treatment, especially in pediatric patients. This is what you see commonly in these pediatric patients, so they get these giant cystic craniopharyngiomas, and you can see they essentially all, almost all have recurrence, and so they're managed in a variety of ways, focused on managing the cyst itself. Much higher rates of recurrence in the cystic tumors, so very significant to watch and really be more aggressive at treatment of these. Here's a recent patient I had, and this goes back to sort of approach selection as well. So here's a tumor that I thought I could get a pretty good resection of the majority of it from an endonasal approach, but you can see the tumor extending laterally. So I did both an endonasal and an eyebrow approach to try to get all of the arachnoid tumor lateral to the optic nerve, but all of the retrochiasmatic tumor from an endonasal approach. And we did preserve the stalk in this patient, although her function long-term has not held up, although she's avoided diabetes insipidus. So here I'm trying to avoid recurrence, but whatever approach is necessary should be used to get the most complete resection you can. Now here's a patient that was sent with a multiply recurrent tumor. The patient had an ommaya, they had a shunt, they had a transventricular approach from above, they had a standard craniotomy from above. You can see the left terional, and they have an ommaya in a cyst, and they have slow progressive, and the patient has had full dose IMRT. So there's it's asymptomatic, it's a growth, it's a very solid tumor. We can't really do more radiation, so this one very obviously needs at least attempt at resection. Now, people might say, well, endonasal approach is a very calcified tumor. That's not really an option. So here we can see, you can see that ommaya, that ventricular catheter that was placed into the cyst itself. And here we just have to be persistent. So carefully working around the tumor. You can see it's very adherent to the basilar. And this tumor goes quite low, so this would be very challenging from an open transcranial approach, even going transcavernous because of how low the tumor goes. Here I'm even stabilizing the tumor and trying to drill it. By breaking it into pieces, I can manage to break the tumor apart. When you have a calcified tumor like this, there are solid components mixed in with a calcified component. Certainly radiation is not going to make a calcified tumor like this shrink. And in addition, this patient has already failed radiation, which is probably not surprising. So here we can see now coming up behind the chiasm, we have a beautiful view onto the floor of the third ventricle. You can see residual solid thick tumor there, the calcified component as well. And in the end, we can break this up somewhat, but I can't really get it off of the basilar. It's too adherent. So I decided to leave a small amount of this calcified component on there. You can see it coming off of the basilar on one side, but the perforators really can't be protected with a tumor like this. Here's our final view. Resected most of the tumor, only a couple of small calcified components right on the basilar itself. And the child did quite well after this. And last I heard, he has not had a further recurrence. So I really think that this algorithm works pretty well. It may seem overly simplistic, but the truth is, if it is not symptomatic and you can safely treat it with stereotactic radiosurgery, I believe that that's a good way to approach these tumors. The risk of that is very low. I've not seen high risk of damage to any of the structures, including hypothalamus with radiosurgery. But if the tumor is symptomatic or large, or it hasn't had a good resection before, you should consider re-resection in these patients. Don't forget about the BRAF positive tumors. Bleomycin really, I think, should become first line for recurrent tumors because it may provide long-term control of these tumors once they start to recur. To summarize, craniopharyngioma recurrence, whenever possible, avoid it by getting a gross total resection. But your recurrence really has to balance between stereotactic radiosurgery, resection, and cyst treatment. And it's a constant movement between these by understanding where the recurrence is and what symptoms that might cause. Remember that recurrence will lead to loss of pituitary function. So I think it's appropriate to consider loss of function at the first surgery if gross total resection is possible. Again, want to always invite everyone for this online congress, as well as to visit us in Pittsburgh in person for the Pittsburgh course. And then I hope to see everybody at the North American Skull Base Society, which is being done in combination with the World Federation of Skull Base Societies and then the European Skull-Base Society meeting in my mother's hometown of Zagreb. Hope to see everyone there, and thank you again.
Thank you, Paul. That was a very nice, insightful input on how we can, use resection as well as bleomycin and radiosurgery, when we are dealing with complex recurrences. We have one question from the floor, which I'll start with. They'd like to know when would you not use an endoscopic approach? I know there's a lot of standard information in books on this, but your on this.
Yeah, so I think there are a couple of cases. I've actually gone, as was mentioned, the third ventricular tumors, I think traditionally I had done transcranially, but their attachment is right at the base of the hypothalamus. So if there's enough space between the optic chiasm and the pituitary gland, then I will go actually endonasally into those. And I think you can find that opening through the floor of the third ventricle, which is what you're going to come through any approach, and you can find the attachment of the tumor. And then I agree completely that higher up, the tumor is not attached to the walls. It only has one or two attachments. Once you release those, you can debulk the tumor and deliver it either endonasally or transcranially. But I would say that third ventricular tumors are good tumors for a transcranial approach. And then the tumors that really extend laterally anterior to the chiasm significantly, or especially out to the sylvian fissure. But the origin of all of these tumors really is in the stalk, in the majority of the cases. And so these extraventricular ones where it's originating in the stalk, your most direct access is endonasal.
Right, understood. Thank you for that. Sabino, would you like to bring up any questions?
Yeah, no question, just a comment. Thank you very much for giving us this very critical concept about the fact